When a patient presents with hyperthyroidism, distinguishing between true hyperthyroidism, which is due to excessive hormonal synthesis of thyroid hormone, and thyroiditis, which is leakage of thyroid hormone due to inflammation of thyroid gland, is one of the most intellectually rewarding and clinically vital duty of the treating physician. Missing this distinction lead on to inappropriate treatment, unnecessary cost, and potential patient harm. The pathophysical divergence. To manage these patients, we must first know the mechanism of hormone elevation. In hyperthyroidism, as in Graves and toxic multinodular goiter, thyroid factor is in overdrive. There is increased T3, T4 production from de novo synthesis. In thyroiditis, like subacute painless postpartum, the gland or the warehouse is broken down. Inflammation causes the preformed colloid to leak into the circulation. The clinical pitfall both present with suppressed TSH, elevated FT4, elevated FT3. However, treating leaking hormones with antithyroid drugs like methimazole is physiologically futile because the factory is in the problem, the door is. So, high yield differential between these two. When a patient presents with thyrotoxicosis, use the clinical and biochemical clues to pivot towards thyroiditis. The clinical clue is that pain and tenderness, as in subacute granulomatous thyroiditis or dicuvirin. Look at the exquisite tenderness, often preceded by a viral prodrome. The pain may radiate to the jaw or the ears, mimic a dental issue or an otitis externa. While silent thyroiditis clinically is identical to Graves but lacking ophthalmopathy, pretibial myxedema, or a bruit. The biochemical footprint is the T3-T4 ratio. In Graves, the hyperactive gland preferentially secretes T3. So the T3-T4 ratio would be more than 20, while in thyroiditis, T3-T4 ratio is less than 20, since the leak reflects stored thyroid, which is preferentially T4. Inflammatory markers ESR and CRP are characteristically sky high. In subacute, it will be tune of 100. In Graves and painless thyroiditis, they are typically normal. The gold standard is radioiodine uptake. Look for it's a fork in the road. High or normal uptake is indicative of Graves or toxic MNG or a toxic adenoma. Low or absent uptake of less than 5% is seen in thyroiditis because inflamed cell cannot trap iodine. Also in factitious and recent contrast use. So always ask for recent IV contrast or kelp supplement before ordering a radioactive iodine uptake because that may show a false low. What is the importance of avoiding iatrogenic hypothyroidism by starting methimazole in a patient with thyroiditis is quite pivotal because after the thyrotoxic phase, there will be a hypothyroid phase where there is no more hormone. So if you add methimazole, it will prolong the hypothyroid phase. Hypothyroidism requires antithyroid drugs, while thyroiditis, the management is purely symptomatic by using beta blockers and NSAIDs to prevent pain. Thyroiditis is often triphasic. There is a thyrotoxic phase, followed by a hypothyroid phase, followed by a euthyroid phase. So counseling the patient gives him immense happiness because it's a benign self-limited disease most of the time.